full agenda of wonderful content. This is Michelle Jester. I'm with the National Association of Community Health Centers, and I've been working with my colleagues at the National Center for Medical Legal Partnership and the Corporation for Supportive Housing over this past month to put together this learning collaborative around leveraging Medicaid policies to address social determinants. This is our last session, so thank you guys for being with us for this entire month. And we're excited to talk to you guys today about, now that you've heard about the different Medicaid programs and waivers that you can take advantage of, we want to talk to you about strategies that you can use to really engage and inform that waiver process and how you can really ensure that you are pursuing the positive aspects of it and then pushing back on potentially any negative repercussions from it as well. So before we get started, I'm going to turn over to my colleague Jen, who's going to run through a few logistical things, and then we're going to launch our first poll.
Thanks, Michelle. So hello and welcome everyone to the webinar. We will be, I'm just going to go over a few logistics with everyone. As a reminder, everyone is muted during this call just to reduce background noise. And this call will be recorded and available to everyone at a later time. As Michelle said, we are going to open up a poll which should pop up on the right side of your screen below the chat box. And you can go, and we're going to leave that poll open while we proceed with the webinar. So please feel free to put in your results, and we will look at the results in a few minutes.
Great. Thank you so much, Jen. And Jen, would you mind? Oh, perfect. Great. And next slide. Next slide. Perfect. Just a reminder that we do have the Slack community that is still open, so if you are looking to engage with others on this learning community, or if you are looking for resources, or if you have information or resources that you'd like to share, the Slack community is a great place to do that. So please feel free to check that out even after this learning community. Next slide. And then depending on how many people are on, when we come to our Q&A and discussion sections, we will likely have people input their questions in the chat box. So just here's a quick reminder about how you can access the chat and then put in your message. If there aren't too many people, we can try unmuting everyone, but there's often too much background noise that we find that the chat is probably the best way to raise your questions. Next slide. Okay. So just to do a little bit deeper dive as to what we'll cover today, we really want to kind of help you compare and contrast different approaches for engaging those key state and Medicaid stakeholders to inform Medicaid waiver development process. We want you to be able to figure out what are some successful messaging or data points or resources that health centers and PCAs and networks have used to really inform the waiver process, and then leave you with ability to develop your own strategies for getting involved and informing Medicaid waiver process as well. Next slide. We're going to do that through a panel of amazing speakers. So we will first hear from my colleague, Bethany Hamilton, who is the Deputy Director of State Affairs, and she's going to kind of give you an overview of the Medicaid waiver process and all the points in which you can engage. Where they're going to hear from the North Carolina PCA, Kristen Dubé, who will talk about their experience engaging with their Medicaid agency on the 1115 waiver that was focused on social determinants and creating a statewide social determinant of health tool. We're then going to pause and have Q&A for North Carolina and Bethany at that point because Kristen has to get off before 4 o'clock to join another call. But then we will pick it right back up to hear a health center perspective from the Family Health Center of Louisville, Melissa Noyes-Mather, who's the Director of Communications. And they have done a slew of things, so many strategies, so many different ways that they have engaged with their Medicaid waiver process and their community and their staff just to promote and educate and inform. We'll then have another round of Q&A if you guys have questions for Melissa, and then we want to hear from you guys, since this is the last session, on what you thought about this learning collaborative and what we could do in the future. Great. Next slide. I kind of briefly introduced the faculty already, but here they are in person so that you can see. Amazing panel. And with that, I believe, Jen, do you mind closing the poll?
Great, Michelle. I just closed the poll. It's going to take about 10 seconds to load, and then I'll post that up for everyone to view.
Wonderful. Thank you. And then do you mind going to the next slide, Jen? Great. Okay, so it seems that some of you guys have engaged. So when we come to discussion time, maybe it would be great if you guys wouldn't mind sharing your strategies and what's worked well and what you've struggled with, so that we can all learn from each other in this learning collaborative. But with that, Jen, do you mind passing the ball to Bethany? And oh, great, you already have. And Bethany, the floor is yours. If you want to advance to the next slide, which should be yours.
Great. Thank you so much, Michelle and Jen. Good afternoon, everyone. As Michelle mentioned, I'm a Deputy Director on the State Affairs team here at NAC. Most of my time and days over the last couple of years have probably matched several of you if you work on policy at the state level, and we've all been dealing with the slew of state 1115 Medicaid waivers, the proposals, the approvals, the implementation. We've all been in that space. Some of what I would like to offer to you are some tips on how to engage in the process. If you are not a health center, I know several of you on today's call are not health centers. This is not just advice for health center engagement in the 1115 Medicaid waiver process, but hopefully you too at your organization can help inform the health centers and as well the Medicaid waiver process. So hopefully this will be relevant to everyone. Okay, so what I found over the last couple of years is that the question really isn't to engage or not to engage. It's really a slew of questions that assume that you are going to engage, starting from you're basically like who, what, when, where, why. But what I do call out in today's presentation is the why, the when, the how, the where, and with whom, because many of you, including those of us here at NAC, don't just engage standing alone as NAC, but also in partnerships. So just a very quick overview, and I know throughout the series of webinars, you all have probably gone over some of this, so I'm going to go through not everything on the screen, but do send a chat and let me know if you have any questions, because I'll just do this very quickly. But this is the what and the why. So the Section 1115 Medicaid waivers aren't the only type of Medicaid waivers. In fact, Section 1115 actually pertains to several health and human services programs, but 1115 is the broadest section of the Social Security Act, and where folks take advantage, states and the federal government take advantage of allowing for great state flexibility for the Medicaid program. The state Section 1115 Medicaid waivers are sometimes, or most of the time I'll say good, and then sometimes they can be harmful. In either scenario, engaging in terms of comment and informing and even the formation of a proposal is going to be necessary and quite helpful, and can sometimes and oftentimes actually prevent from harmful effects on your beneficiaries as well as the health center staff and operations. Do know that although the Section 1115 waivers are very, very broad, the Secretary of HHS does not have unbridled power. So first of all, the Medicaid waivers that come under Section 1115 must promote the objectives of the Medicaid program, and also the waivers are specifically limited to waiving sections of Section 1902 of the Social Security Act. These are obviously different from state plan amendments, which will accomplish things that are not trying to change or do something that will diverge from the rules. But you also see very similar aspects of state flexibility being carried out in state plan amendments. There's a reason why I'm bringing up that distinction, and you guys will see that a little bit in just a couple minutes. So next, when should you engage or can you engage in a Medicaid waiver process? I would argue that you should be engaging at all times. That means before, during the waiver proposal or concept stage, and certainly after, which is the duration of a waiver, that either 3-year period or 5-year period, and then even afterwards, because you're not just informing folks with regard to how the waiver is being implemented, but then after a waiver might close out, if a state doesn't renew it or continue in that waiver program, you may want to continue to inform on what the long-term impacts are, or perhaps you want that waiver program to come back. So my argument is that because you're talking about a federal-state partnership and you are, in fact, a part of the partnership circle or system for the healthcare delivery aspects of the program, you should be engaging at all times. The however that I have here, and hopefully it's just showing up on the screen. So Jen and Michelle, let me know if the screen is cut off, because there's a however note there that I hope folks can see, and that really is pertaining to the technical requirements for the Medicaid waivers, and that'll determine how and when, specifically when there's a waiver, you would engage. In case you could not see what was showing up at the bottom of the screen, worry not. I actually have a copy of a timeline that Kaiser, I apologize to anyone from Kaiser on here. I do have a citation showing up on the bottom of the slide. It's just cut off on my screen at least. But this timeline that you see on the screen is really easy, clean timeline representing a waiver proposal, state level and federal level comments. So this is technically, according to the federal rules, the timeline for the waiver proposal. You will see that on the beginning and at the tail end of the timelines, I've added some notes. So there's the pre-waiver proposal, and sometimes it's a concept paper. My argument is that you're always engaging. So even before a concept paper comes out for a waiver proposal, a health center is informing a PCA or sitting at the table on advisory groups, letting the state agency and any other state partners know exactly what the value is of a health center. That's all of the stuff that happens before a waiver proposal ever comes out. But once the state actually releases the waiver proposal, the public notice and comment period opens up for 30 days. And I think our expectation, as well as the PCA's, is that a health center is directly engaging the PCA and keeping the PCA informed of any concerns they may have in their particular community. Some rural communities will certainly have concerns that differ from an urban community, or perhaps they want to make sure that all of their concerns are well aligned and they share those concerns no matter what the community looks like within the state. But then after the state closes out its public notice and comment period, which has to be at least 30 days, and they've held hearings, then they send that proposal off to CMS. CMS has to make a determination that that application is complete, or the proposal is complete and all of its pieces and parts, which are also laid out in the federal rules. Some of that is also laid out in statute. But then once it's deemed complete, CMS will then open up its own federal level 30-day comment period. And at the end of that period, that's when you can expect to see an approval. When you can expect to see an approval definitely, I would say, varies, and it's even hard to tell, given the current administration, even on aspects of waiver proposals that they have clearly approved. There's not a real trend in terms of timeline for approvals, even on waiver proposals that look exactly alike. So it's really hard to tell. Nevertheless, one should also comment at the federal level, even if it's just for the sake of repeating and ensuring that the comments you made at the state level are still on the record and being considered by CMS at the federal level. So you're raising awareness throughout regarding your concerns. And it's not just concerns that something may be harmful, but it's also that something may be helpful, and you want to make sure you are either supportive or that your concerns that someone else may have that could eliminate some aspect of that waiver proposal, you've made that known that you actually support some aspect of the proposal. And I also mentioned, of course, I just want to reiterate that the engagement continues. So during that waiver period, you're continuing to raise awareness. You're talking about implementation, because a lot of times, as you all know, something can be great in writing, but upon implementation, that's where you really find out if it works. So continue to engage. All right. So I've alluded to this quite a bit, but the awareness level 101 that I wanted to share is really that keep in mind the engagement piece is really a never-ending loop where you're keeping people informed and you're also staying informed. And so what I found is that talking to a PCA, because they work directly with the state on a lot of the policy issues, they know well before some of the health centers do that a waiver proposal is coming up. I think the job of a health center is also to ensure that they are receiving that information from the PCAs, and so it's perfectly fine, and you'll hear from both of these folks in a moment as to how in their states they have, as PCA or as health center, kept folks vice versa informed. But the minute you make that demand, also ensure that you are providing the information that the PCA or whoever the folks are that are informing the state agency, they know about what the value is of the health center's role in the Medicaid program, and that you know as well as a health center what some of the rules are with regard to how much can be waived or whether or not this is something that really should be in a state plan amendment. So that's the side note number one. Is this really something that needs to be in a waiver, or should it just be in the state plan amendment, which really is the path of least resistance? That's where a state has not just flexibility, but they also don't have as many hoops to jump through in terms of like evaluations or budget neutrality statements. They're following most of the rules. They're just making some reforms via state plan amendment. The side note number two is related to the process. So typically what you're looking at if you have a bona fide waiver proposal is it a brand new proposal? Is it a renewal of an existing waiver that was approved by CMS and has been implemented by the state? Or is it a temporary extension so that the state can work something out? Those are all time periods during which you will want to continue to be engaged. But when it comes to an amendment of a proposal, you may not, just because of the way the rules are written, you actually may not have an opportunity to engage formally via the public notice and comment period at the state level. That's where CMS will offer a public notice and comment period, but the state doesn't necessarily have to. Several states have still offered a public notice and comment period for amendments of waiver proposals, but they don't necessarily have to. And that actually came up with at least one of the states on today's webinar. Awareness lesson 202. Knowing the rules is really important, and this goes to like how you're engaging. What is it that you are actually raising in terms of concerns, whether it be during a hearing or a comment, or just continuing to raise awareness throughout your engagement with the state agency or even with CMS, right? Sometimes, as folks know, NAC brings folks in to really have those one-on-one conversations with CMS and the state, and we also have some peer learning groups like this one, where sometimes CMS or a state agency might be on, not necessarily this one today, but sometimes we do, and it's really just a peer learning structure, and that's a good place to be able to raise awareness as to the mission and mandate of F2HCs as Section 330 grantees. Also, when you're talking about the value of F2HCs, that's where the conversation comes in with regard to those Title 19 protections related to F2HC services and the payment mandates under federal Medicaid law. Also, a step further in terms of like being at least aware of, or if not totally familiar with every single aspect of your legal protections, F2HCs may also have additional protections under state Medicaid law with regard to their service and payment that they are due. So it's good to at least know, hey, we've got some legitimate stake and interest in these changes and reforms, whether it be via a waiver or via a SPA, or we just want to maintain, and here's why. And the reason I noted that you've got mission or mandate statements or value statements to make is because sometimes these are difficult topics to bring up. Service and payment protections, right? That alludes to you being, as an F2HC, something special. Indeed, you are. But what that means is that what it could connote or suggest is that someone else is not so special. That's not the case, but what you want to do is explain exactly why you do have those service and payment protections in place. And that really is because Congress and the state and CMS have really valued what the F2HCs provide to the overall healthcare system and the Medicaid enrollees. Okay, so when you're commenting, what do you want to mention? I've already touched on some of this. I'm not going to read through this entire list. I think something also got cut off. But if you're crafting statements for hearing testimony or for comments, think about some of these things. So again, does the waiver proposal or even the concept promote the federal Medicaid objectives, which is primarily to provide medical assistance to low-income individuals. So if you see a waiver proposal that may cause folks to lose coverage, that's something to raise, right? Is this actually meeting the objectives of the federal Medicaid program? What's actually being waived? Pay specific attention beyond all of the initial statements about other lofty goals. What exactly is being waived? Is the state trying to waive some of the premium or cost sharing requirements? Is some eligibility restriction being added? And then also I noted pay specific attention to the special terms and conditions, because that's where you'll see what the waiver really gets done and what you as an FQHC or any other provider type or even a state or an MCO might be held to, and also what the beneficiaries might be held to and what the impact is on them. It's in the special terms and conditions. You'll see some other notes there about data, looking at the waiver proposal with regard to its research purpose. So in the draft evaluation plan or in the hypothesis, does it all make sense? Is there some evidence suggested to support the research and demonstration aspect of the Medicaid waiver proposal? Those are things to consider. After, however, a waiver is approved, don't give up. Still, your engagement continues, and you're going to be looking for example, did you actually have an opportunity to provide input on what you see CMS actually and finally approved? Another thing to look at is take a step back. Once the state submits that proposal to CMS, did something change once CMS put it out for public notice and comment? And were your comments at the state level also taken into consideration and substantively addressed? Similarly, if you brought up any statutory or regulatory hurdles or issues, were those addressed and overcome, whether it be at the state level or at the CMS or federal comments level? And then I think what got cut off on the bottom of the screen here is really whether there was any evidence of presented related to value or impact of the proposal to the beneficiary. So oftentimes FQHCs can easily point to UDS data, but the UDS data doesn't always capture everything about impact. So there might be some capacity issues that aren't represented at all in the UDS, and that's something that you will want to bring up and see addressed appropriately once that waiver proposal is approved. If you're partnering, and NAC does this quite often, so I would imagine that FQHCs, we expect FQHCs to partner by coordinating with the PCAs, and then PCAs or others will coordinate within the state. If you're doing so, why you're doing so all depends on interest or the strategies, approaches that you're taking, and then you'll decide, okay, who are the right partners. So sometimes you might want to partner if there's a billable issue, billable provider issue that's brought up, or payment issue that's brought up in a waiver proposal. That's something you may want to partner with other provider types like hospitals or other safety net providers within the community to raise concerns about. If there's a general enrollee access issue, that's where you begin to find larger groups of community providers like your legal services community, or even, I would say, other beneficiary or enrollee representatives coming up to be accessible as partners and help you voice your comments and opinions in a really careful and cautious way. What I mean is you can almost take cover in a group by partnering with other folks. On the other hand, depending on the strategy or approach, you may not want to partner. You may want to make your case standing alone, just for whatever the interest or the stakes might be. And as you can see, what I've alluded to in the strategies or approaches is that Medicaid waiver, the process and where you can engage, isn't just in the proposal. Some of these waiver proposals are mandated by legislation or regulations. Some of the waiver aspects might be dealt with in sub-regulatory guidance that you can also inform. And sometimes this plays out upon implementation in the contracting phase. So these are who you partner with and how you engage. Totally depends on the interest, the strategies, and approaches. And then you'll just see the list of examples of types of partners, some of which I had mentioned. All right, so just very quickly, getting to the end here so that the real experts from the states can tell you all about how this really works, or if it doesn't actually work. Again, some practical tips. Make sure if you are an FQHC, and even if you are one of our national partners, be sure that you are coordinating with the state PCAs, and certainly NAC coordinates with every single PCA when a waiver comes up. We don't even comment or sign on to comments unless we've reached out to a PCA to consult on the impact or the language or the tone with regard to a letter. Secondly, waivers can be helpful or harmful. I mentioned that right at the beginning. Just remember, it's just as important to comment on the harmful waivers, or potentially harmful waivers, as it is on the helpful or potentially helpful waivers. Make sure your engagement is all around 365 days a week. I'm not saying 24/7 because work-life balance is indeed important, but do be engaged and build awareness to prevent any harms down the road. And make sure as you're building awareness that what you are building awareness about really is demonstrative of the unique role and value of FQHCs in the Medicaid delivery system, and how that also, I think, feeds into and influences the efficiencies of the remainder of the healthcare system, and perhaps even the general economy within a state. And then if you can, like sometimes we do at the national level, what that impact will be. Also, quick note that'll sum up two bullet points showing up on your screen in one. You can find partners who are your friends in some very unlikely places, and I think we've seen this in a lot of different policy areas, and not just Medicaid waivers. We've seen this on even some drug policy stuff, but know that at certain times you can find some unlikely friends in unlikely places at unexpected times. So be sure to really explore all of the different variations of possible coalitions and partnerships that can come up. I can tell you with my background as a lawyer, one of the things that people joke about, probably also in med school, but certainly in law school, is that lawyers and doctors don't like each other. That's absolutely not true, and that's where a lot of these partnerships and coalitions come up and work very, very well. It's in the Medicaid waiver space. And then also, finally, I just want to make sure you all note, again, I think this is cut off on the screen, but seek compromise. Just do not sacrifice your identity, mission, or legal protections as an FQHC or a safety net provider. It's really, really important. You'll be pushed to your limit on some of these Medicaid waivers and in general on Medicaid policy, but don't lose sight of the big picture or your identity and mission. I'm going to stop there because you're welcome to put anything in the chat box for Q&A, but I want to make sure that you are now able to hear directly from the real experts. So I'm going to pass the ball to, I'm trying to find you, Kristen, in the list. So Jen and Michelle, if you could help me pass the ball to Kristen Dubé, that would be great. I appreciate that. And thank you, everyone.
Kristen, you now have control. Okay. Great, thank you.
Okay, great. Can everyone hear me okay?
Yep, we can hear just fine.
Good. I'm sorry that I have to jump off just before 4 o'clock, so East Coast time, so I'll try to make it quick, and I'll try to talk as clearly as I can while I'm speaking quickly. I know you all wanted me to talk a little bit about how we're moving on social determinants of health in our North Carolina Medicaid transformation process, and I think in order to speak clearly about that, I need to give you an overview of what's happening in North Carolina. So just so you know, we're moving into Medicaid managed care. We are currently in, at least for the physical health side, we're in a fee-for-service Medicaid program, so providers are paid directly by the state. And in 2015, our state legislature, looking for more budget predictability, passed legislation that would move us to Medicaid managed care. Now, that was 2015, and the process is taking a long time in North Carolina. We're not one of those states that moves really quickly on these things, which is probably good. But we finally had our 1115 waiver approved by CMS in October of last year. We've definitely been working a lot on moving to Medicaid managed care in that time frame, but we've had lots of opportunities to comment, and I'll talk a little bit about that later. But we will be moving to Medicaid managed care. We're going to have 4 statewide entities, and then we have our state divided into 6 regions, and 2 of those regions will have what's called a provider-led entity in North Carolina, and that's going to be a regional entity. It has provider ownership, and in full disclosure, the FQHCs, our association, the North Carolina Medical Society, are part owners in that plan with Centene Corporation. So there will be 5 total managed care groups working in North Carolina, and 4 of those will be statewide. We'll have about 1.6 million beneficiaries that will be in Medicaid managed care. Now, we are going slowly. Not all services and not all populations will be going to Medicaid managed care at this point. Most will, though. So dual eligibles will come later. They will remain in fee-for-service for now, and dental and eyeglasses are remaining in the fee-for-service world. But one of the things as we move to Medicaid managed care, there's a major focus in North Carolina on maintaining our local care management infrastructure. For a long time, we've had a very strong medical home model with Community Care of North Carolina, which really provided care management and a medical home for patients. So it provided kind of a boost in payment to providers to serve as a medical home and make sure that patients know where they can get their care on an ongoing basis. And as well, there's been a care management infrastructure layered on top of that through a program called Community Care of North Carolina that's been able to assist providers in their treatment of patients by, managing the care for, kind of doing some like local care management for those patients, making sure they're connected to the other services that they need. So we're layering on top of that and hoping to enhance that and even bring it more closely at the provider level for care management in the new system. So some providers, depending on whether or not they attest to being able to provide care management services, will be able to bring some care management dollars and care management services in-house themselves. So we're waiting with bated breath to see how it all is going to work out. We will go live in 2 regions in November of this year, and then statewide will go live in February of next year. So that's the idea, is to do it in a stepwise fashion, get some of the challenges and things that come up worked out for both the beneficiaries and the providers before we go fully statewide. And then one of the really exciting components about our 1115 waiver is its focus on addressing social determinants of health. And we've got a number of initiatives that I'll talk about related to that as part of our waiver. And I think it's important when we're talking about framing this, that North Carolina Medicaid and Department of Health and Human Services more broadly really focuses not on social determinants of health, but on opportunities for health. So they've been really strategic when they've been messaging this to say they really want to help with health-related resource needs. And their language is specifically, they say the opportunity for health begins in our families and the communities. The opportunity for health begins where we live, learn, work, pray, and play. And I think that has been really, has made providers and the provider community feel good about the direction we're moving, because we really feel like there is still a focus on beneficiaries and how providers can't do everything within the medical office, that, they come in for one issue, but really there are several issues in their life, literally where they live, work, and pray, that are impacting their health when they come in to see the doctor or the provider. So North Carolina is really focused on buying health and not health care. And we really value that attention and that focus. And they have always really moved away from the determinants language, because that's so, it seems very final. And we know that a lot of these things continue to impact us, but also can change. And so they may be social drivers of health, and that's how we talk about them internally at our primary care association. And so to talk a little bit more about the state's approach to the health-related resource needs and the strategies that are included in the 1115 waiver, there are some smaller and larger strategies that they're focusing on. They developed a hotspot map that is on the website, and it's broader and it's available for anyone. It's not just for Medicaid beneficiaries. They have developed a screening questionnaire, and I'll talk more about all of these things a little bit more later. And that will standardize how enrollees are screened for unmet health resource needs, and that will be done by all of the Medicaid plans. There's the North Carolina Resource Platform, which is really a technology solution, kind of like an Aunt Bertha or Healthify, if you're familiar with those. And it's really a way to bring together all the resources in a platform where you can search for social service providers in a single location. And also, eventually, it's really hoping to do some kind of closed-loop electronic referral, so we can really see if someone's referred somewhere, are they getting help that they need there? We're still a long way off from that, but that's kind of the hope. There is some talk in the 1115 waiver about incentivizing PHPs is the term we use for Medicaid managed care plans to address social needs. That the details are still hazy, and I think that's important to think about in waivers. And as Bethany was saying, that there are lots of times to engage. There are lots of things that are in waivers that are not very well spelled out, and lots of work has to be done after the waiver is approved, and that's where engagement is really critical. And then there are some healthy opportunity pilots, and you may have heard about these, but CMS did approve some dollars to pay for certain social services for Medicaid beneficiaries, and they're pilots, so they'll be limited, and I'll talk a little bit more about those. And then workforce. We still don't have a community health worker certification or a standard curriculum, so that is something the state continues to work on. And the 4 priority domains that we're working on are food security, housing stability, transportation, and interpersonal safety and toxic stress. Now, there was at one point some discussion about employment, but thus far it's really been left out of most of the work that's happening. And then, so why is this being worked on now in North Carolina? I think our process has been so long in this implementation to Medicaid managed care that, first of all, it was passed in 2015. In 2016, we got a new governor. So even the initial Medicaid waiver proposal was put out in early 2016, and we were responding to that and did provide comments and feedback. And then we had a new administration come in. And then after that, there was, they did an update to modify the proposal as well. So then we had an additional opportunity to comment on the changes the new administration really wanted to focus on. And I think leadership has really been key. Our Governor Cooper, brought in Dr. Mandy Cohen, who was previously Chief Operating Officer and Chief of Staff at CMS. She's also a doctor. We also have a health director who's a pediatrician and has lots of experience working with Medicaid beneficiaries. So both of them really understand that it's not health needs are not all, or health itself is not about what the doctor can do for the patient when they come to see them, but it's really more about what's impacting the patient's life all around and impacting the family. So they really talk about, they want Medicaid to buy health, not just health care. And certainly that has been a wonderful message for our providers to hear. And they're really interested in, promoting health outcomes and addressing disparities, which is, of course, part of the health center mission. So I just put in, North Carolina Community Health Center Association. We have our goals too, and really to make patient and community needs, help to address them, make accessible and comprehensive the care that they can get and other resources that they need. We want to make sure that the Medicaid system is addressing the resources they need, and also make sure the Medicaid system is not overly burdensome either for the beneficiaries or for the providers. And then we think that health centers have a lot to share. We've had a lot of good experience. We have very strong health centers in North Carolina. We want their successes to be incorporated into state strategies as well. And of course, we're always looking at payment systems and want to make sure the complexity of patients that community health centers are serving are recognized and built into that so that we're not being hurt by that. And then, of course, we want to make sure everything they do is adequately reimbursed. Right now, there's not a lot of reimbursement for the work that they do to help patients access resources outside of the clinic, and we want to move in that direction. And then while we're doing this really exciting stuff around social drivers of health, I think it's important to realize that we are in a state that is a non-expansion state. So we are really still focused on hoping to get Medicaid expansion at some point, in whatever form that will be. 42% of community health center patients in North Carolina remain uninsured, and that's huge. So if you're an adult in North Carolina and you don't have a dependent child, you cannot access Medicaid, no matter how low your income is, unless you meet certain other medical needs. But it's a real problem in North Carolina, so we're continuing to hope that we will move in that direction. Talking about engagement, want to say a little bit about with North Carolina Department of Health and Human Services. We engage them in many, many different ways. So, Bethany, I think you went through a really great process of how the formal process of engaging in a waiver, and I didn't put that in here, but I think I should probably speak to that a little bit. So we, when the waiver draft first came out and we had that official opportunity to comment, we developed our own internal primary care association comments, and then we shared them with our a template. We shared the full version and a template, much like the National Association does with federal regulations and comments. We shared a template with our health center members and said, here's what we suggest you submit, and here are some places where you can share your specific experiences about your health centers, and this might be a great place to talk about XYZ or what you're doing around social drivers of health, such and such. So we gave them kind of a template and encouraged them to submit comments as well. As for the hearings, we particularly made sure we had a number of hearings. Our state went well above the 2 hearings that are required, and we made sure we had a representative from our health center at all of the public hearings, and we had comments for them mostly about, the burdens and redundancies that come with potentially a Medicaid managed care system, and had made sure they were giving similar comments so that we made sure the state has heard what we have to say over and over and over again. So there are a lot of times when the state, you go to a meeting and they say, I know what you're going to say. You're going to tell us yada, yada, yada. And we're like, yes. And that's why you continue to go and engage again and again. And even if you're saying the same thing, you want to make sure that you're not going to let them forget how important this is to health centers and the beneficiaries they're serving. And then we had a whole other process when the waiver update came again. So we did that whole process again with our PCA comments, templates for our members, and hearings. The state has also been extraordinarily transparent through this entire process, and we have had so many opportunities. They have put out, I can't even tell you how many policy papers. So the waiver passed, but then it's about implementation. How is all this going to be implemented? So they've been putting out policy paper after policy paper about how these various components of the waiver will be implemented, and they have welcomed feedback on that. And so we continue to give them feedback on those policy papers. We share the policy papers with our members, of course, but also give them kind of bullet points of what's in them and things we think, that may be of concern or areas that we think are really positive. And the one thing that's really interesting, we're talking today about social drivers of health, that was not at all detailed in the waiver. And so later policy papers were part of that process. Some of these things were outlined in the RFP that was put out for the prepaid health plans. And then there is still work going on now around engaging in how the social drivers of health component is going to be play out. So I'll talk a little bit more about that, but there are just certainly lots and lots of opportunities and ways that we are engaging with the state, but we are certainly taking every formal opportunity and doing so in informal ways as well. And then on the social drivers of health, we are making sure that is a priority issue that we are talking about at our conferences. We are making sure to bring that up when we are in meetings with folks at the state level, with other constituency groups. We want to make sure that is at the forefront of people's minds and that they know it's important for our members and the patients that they're serving. Let's see here. Okay. So talking a little bit about the strategies, the specific strategies the state is using within the waiver around social drivers of health. One of the most exciting things, I think, is the screening process. So essentially, North Carolina has developed a standardized social determinants of health screening tool that all of the Medicaid managed care plans will be required to use. They will have to share the results of those with the providers so the providers can provide better care for the enrollees. And each PHP will kind of define for their plan what the high and, how you meet quote unquote high unmet resource needs, but you'll definitely need it if you have homelessness, domestic violence, lack personal safety, or you positively screen on the screening tool for 3 or more core social determinants of health domains. And then the plans will incorporate that high unmet resource needs score into their risk scoring and stratification for care management. And I think what's particularly important is that they're all going to be doing the same thing. From the provider perspective, certainly that we want to make sure that we're not treating patients differently. We're going to try to be rolling out a lot of this for other patients. So for us, it's not just Medicaid, but the full spectrum of our patient population. And I think from a data perspective, it's really important that the data is coming in that all Medicaid beneficiaries are being screened in the same way. In developing the questions, that is an area where the state actually asked the Community Health Center Association, so the PCA, to participate in this technical advisory group that would make up the questions, and also asked us for suggestions of health centers who would participate. And we thought it was really important when we suggested health center participants because we wanted them to have been already using Prepare. We wanted them to already be a health center that had a comprehensive strategy to address a positive screen. So it's not just that they have a resource list, but they can go beyond that to help them address the challenges that they're facing. And then we also want to make sure different geographic groups were represented and different levels of staff. So we had the CEO from Roanoke Chowan Community Health Center. We had our association was represented. We had the medical director from Lincoln Community Health Center. So both rural and urban were represented. And kind of between those calls with the technical advisory group, the folks who were participating from the health center world got together and would talk about how they really wanted to promote Prepare questions as much as possible. Really wanted to take advantage of the experience they had and using that. And so I did just put, I have to thank my colleague Alice Pollard, who this is really her area, but she was unavailable today. So she put these together and she put in the questions. These are the screening tool questions, and I won't go through them exactly, but you can see that there is 1 to 3 questions on each of the primary 4 domains, and she's highlighted in yellow where the question is also on the Prepare screening tool. And then there are some optional added questions. So I think a lot of people in the group felt that it was really important that once you ask people if they've had these challenges, it might be important for the person who's asking to say, and now do you need any help with any of these needs? Because you don't want to just say, oh, have you had these? Okay, see ya. But do you need any help? And then to be able to do what they can to help. And know how urgent these needs are as well. So there are some optional questions that folks can but are not required to ask. And we'll see, if the plans are doing them, how much they will be asking those or not. And then there's the state resource platform, NCCare 360. So this is kind of that technology resource platform we talked about, similar to Aunt Bertha and Healthify. The Unite Us is going to help that group is going to help to get the community resources onto the platform, and Expound is kind of that data repository, and then 211 is going to be one way that people can already call 211 to get information, and that's going to be another way to get information and for beneficiaries, but the general public will also have access to NCCare 360 and the resources that are on it, and they will be able to call in or use it online and to access these resources. So they're currently in the process of getting local groups signed up, and this is currently being rolled out, and we're having plenty of opportunity to engage with these groups as well. And then we have the Healthy Opportunities Pilot, which is another component of the 1115 waiver that I think is really exciting. So together, Department of Health and Human Services and CMS developed a list of covered services that could be included in these pilots. And examples might be one-time payments to secure housing, medically tailored meal delivery, and evidence-based parenting support programs. So CMS authorized this for a 5-year period, and this is kind of a big deal because it is extra dollars to try something new, and it's not a small amount of money. So I think our state is really excited, but also knows that CMS is watching this very carefully. And so they're going to test the impact of providing these evidence-based interventions to Medicaid enrollees in 2 to 4 geographic areas of the state, and those are yet to be determined. So this is rolling out later than the go live managed care. I think we're looking at next summer, so kind of 6 months after statewide, we'll be ramping these up. And there's about $650 million in Medicaid funding, so that funding is going to go through the Medicaid managed care plans to pay for CMS-approved evidence-based interventions around the 4 priority areas. And any PHP that has enrollees in the geographic area of the pilot will have to participate in the pilot as well. There will be a lead pilot entity for each of the regions or each pilot, and they will kind of bridge the gap between the social service and human service organizations, between the healthcare providers and with the PHPs to kind of connect everything together. So we hope, and there will be a rigorous evaluation of it, of course, and we hope that it will be really successful, and we're in the process of learning more about that now. We continue to engage on this. There will be some meetings coming up soon that are going to talk about what should the state be paying for a certain type of social service? If you get this kind of referral, what would they pay for that kind of service? And so that is kind of being ironed out through a committee right now. One of our health center CEOs who responded to a request for information about what the cost should be is going to be on that committee as well, that's working on that. Messaging and strategies, I just think that, as we've gone through this process, we have made sure to reiterate a number of things. This is not, since the beginning of the health center movement, community health centers have been working on issues that count as social drivers of health at this point, even if they weren't called that then. So this isn't new work for health centers. But of course, if there are more resources, we could probably do this better. And we love the idea of being more coordinated and more resources being available for our partners who are providing a lot of the services that are outside, outside the mission or the work that health centers do, but are really important to getting healthy, getting communities and individuals healthy. And then we keep reiterating that health centers are serving everyone, not just Medicaid beneficiaries. So when we go into these meetings, we are like, yeah, we know you guys are all talking about Medicaid beneficiaries, but when we're thinking about this, we're thinking about how can we make this work for all of our patients? How can we make this work for the uninsured? And we're acutely aware of, the pilots and how all these resources going to social service agencies for Medicaid beneficiaries. Well, how will that impact uninsured patients who also need a lot of those services as well? And, health centers are leaders, so we really want the state and others to utilize health centers for their expertise and experience and tap into them as a resource. And we don't want them to recreate the wheel. The Prepare tool is there, so we've been talking about how, really need to use some of the lessons learned from Prepare. And we message to everyone, so it's not just the department. And like I said before, really, social drivers of health is important to us in all ways, not just in Medicaid, so we make sure that's a focus at a lot of our conferences and meetings and work like that. So I ran through it pretty quickly, and I have just a few minutes, maybe 5, for some questions. So thanks for having me.
Thank you so much, Kristen and Bethany. If people have questions, again, Kristen has to jump off, but please feel free to start putting them in the chat box. I learned a lot. That was great.
Good.
People might be typing as we're chatting, but I'd be curious to know from the group if there are some strategies that they are seeing that they could apply, or what are some take-home aha messages that you could use with your own health center.
Oh, and should I should probably pass the ball to someone else. Who should I pass that to?
Oh, okay. Jen's on it. Thank you, Jen.
Oh, you got it?
Yeah, thank you.
Yeah.
Not seeing any questions coming.
So, Michelle, this is Bethany. I just will note to everyone that I think Kristen in North Carolina and Melissa is coming up. She's showing up still as Michelle Jester, number 2. But they are the real experts on the ground, and so folks should feel free afterwards, I think to reach out to them for tips on how this really works, the before, the during, the after, on awareness and commenting, and ask them about their successes and challenges. Kristen already provided some details on a lot of the back and forth, some of the vagueness in the proposals, and how in the implementation stage, that's where they really got down to work with the state. So I would encourage folks to, hopefully they won't hate me for doing this to them in North Carolina and Kentucky, but reach out to them. They're the real experts.
Oh, no, absolutely. We've learned a lot in this process, a lot of things to do and not to do, so we're happy to share what we've learned.
Bethany and Kristen, it seems like there is a question from Ruben, who's in Texas, and do you guys know, is there something similar happening in Texas in regards to healthy opportunities?
I know there's a, so I don't know if and I apologize because and I'm losing track of all of the different waivers. This is Bethany again. So when I say losing track, that's because I'm working at the national level, looking at all of the states and the territories and their issues. I know there was like the Healthy Texas Women waiver. There's the big, huge Texas District waiver. There are, I would argue again, always opportunities, even if there isn't an open public notice and comment period, because during the implementation stage, that's where the state itself at the agency level is looking at ways that waiver program is or is not working, and also they are required to produce or evaluate the waiver. So because they're evaluating, you should be providing impact. They're using the data from the health centers or other provider types or others within the waiver program, and maybe it's an MCO and they're looking at claims data. So that's why I really do stress and emphasize that engagement occurs at all times, and certainly in a formal way during the public and notice comment period. The easiest way to check and see if there is a formal public notice and comment period that's open is by going to either the state website, if it's still at the state level, and looking at their Medicaid agency webpage, and that's where they're required, because the rules do spell this out to that degree of detail in this regard, whether or not a state has to post it on their website. So they'll post a notice and they'll say when they'll have hearings coming up, and then you'll be able to click on a link to the exact waiver proposal. Same thing at the federal level. You can go to Medicaid.gov, and then there will be a drop-down menu for the Medicaid waivers, and you can see when you select the specific state, if that waiver is posted and open for public notice and comment. And you can also, even if the comment period is closed, go into the link and see what comments. There's a separate link for comments, but you can also see how others have commented in the past.
Awesome. Thank you, Bethany. It seems like, Ruben, if you're just making sure you're seeing it, Marcella has some knowledge about what's happening in Texas. Thank you, Marcella, for doing that. Kristen, thank you so much. I know you need to jump off.
Yeah, I'm sorry to miss the other presentation, but thanks so much for having me.
Not at all. That was great. Thank you so much.
All right. Have a good one. Bye-bye.
Great. Marcella, sorry, I didn't mean to cut you off. Did you want to say anything?
Nope, I'm good. It's all in the chat.
Okay. Thank you so much for doing that. Great. Well, if you guys continue to have questions, feel free to put them in the chat box, but otherwise I'm going to pass it on to Melissa, who can provide a health center perspective.
Great. I know I have the ball.
Great.
Let's see, do I have the presentation?
Other way. There you go.
Perfect. Wonderful. Okay, well, thank you all so much for inviting myself and the Family Health Centers of Louisville, Kentucky to talk about our experience here in Kentucky. I have a lot, so I'm just going to kind of skip over some things pretty quickly. Family Health Centers, we are what used to be considered a large FQHC. I'm not sure anymore, but we served about 43,000 patients last year across 8 sites here in Louisville, Jefferson County. We have 2 specialty sites, one that serves homeless patients, our FHC Phoenix site, and then another site that serves our refugee and immigrant population. And our mix of services, we have dental services, integrated behavioral health, substance abuse services, and just a very diverse patient population that could be affected by the 1115 waiver program that we had kind of teed up here in Kentucky. Medicaid expansion in Kentucky. We expanded Medicaid in Kentucky in 2014 with no strings attached. And just from a pure numbers perspective, we felt that it had been a great success here. In Jefferson County alone, we had close to 76,000 people who are enrolled in Medicaid through the expansion alone. That's 10% of our population, 11% of our population across the state. For family health centers, well, in overall, our uninsured rate dropped significantly. A lot of people talked about Kentucky and the success story that we are, going from about 19% uninsured to 6% uninsured was a great thing for us and for our patients. Our payer mix completely flipped on itself. We went from majority uninsured patients to to 22% today is our uninsured rate. It has gone down to as low as 18%. Our Medicaid revenues had increased by 75%. And our patients who had not been able to see specialty providers and a lot of different care that they needed for a long time, they were suddenly able to get the care that they needed and had been rationing for themselves for so many years. So, in general, the Medicaid expansion for Kentucky, it was wonderful for us. Come to November 2015, we have a changing of the guard. We have a new administration that came in, and when Governor Bevin was elected, his campaign promise was actually to get rid of Medicaid expansion completely. And cooler heads prevailed in the early days of his office, and a lot of the members of General Assembly and different people across the state said, Medicaid expansion has been good for Kentucky. You should pursue an 1115 waiver to adjust the program that might better suit your vision of this program. So the 1115 waiver that Kentucky pursued, it's called Kentucky Health. I'm not going to go into a lot of the different specific parts of it, but please know it's an extremely complex program. Kentucky was first to submit to CMS the work requirement. So we've got that under our belt. But Kentucky Health not only had a work requirement, this PATH program that required 80 hours of employment or volunteer service, public service, or education that needed to be reported each month, it also had a premium and cost-sharing element to it. And it had several other parts of it, whether through the waiver directly or kind of interchanged through the state processes, reported change, missed recertification windows, voluntary withdrawals. Each of these parts of Kentucky Health results in a 6-month penalty lockout of Medicaid. And for these reasons and the overall complexity of the implementation of it, we were very concerned as an organization. Initially, the state estimated that about 100,000 people would lose coverage over a 5-year period. But we know from what's happening in Arkansas on the ground that those numbers were vastly underrepresentative of what would likely happen if we implemented the work requirement here in Kentucky. George Washington University, looking at what happened in Arkansas, they revised the estimates to say that Kentucky would lose close to, anywhere between 86,000 and 136,000 in that first year alone, based upon the work requirements. So you look at the work requirements and the other ways that you can potentially fall off coverage under this waiver, and we were quite concerned for our patients and our community. Not to go too into detail with this, but I'll just say that the implementation process here and the timeline for it has been quite a roller coaster for us. We've gone through essentially two periods. The waiver was introduced. We had our public comment period, a go-live date. CMS approved it. We had a go-live date set, had a whole implementation ramp-up period, and then a judge, Judge Boasberg in D.C., vacated the CMS approval 2 days before that July 1st, 2018 initial go-live date. And then just recently we went through that same process again, CMS comment period, approval, ramp-up period, only to have the judge, again, vacate the approval, this time 5 days before our anticipated go-live date of April 1st. So during those periods in between those start and stop periods, we've been doing a lot of work on the ground with our partner agencies and with the state to be involved in this process. And I think, from the very, very beginning, in looking at, depending on where you are in this process or what are the different elements of the 1115 waiver in your state that are on the table, I think the beginning place where you have to start is to look at what are the elements in the 1115 waiver and what are the likely impacts of that waiver on your patients. And then also look at it from your organizational perspective. What's that impact going to look like for your organization? And, from our perspective, we could look at it and do data assessments in terms of what's the likelihood of the number of patients that we have that would lose coverage, and then be able to do a financial risk assessment for our organization. And then that carries over into what does that look like for our capacity as an organization. So I'm talking about that level of impact, understanding at your patient and organization level. And then also look at, and in the previous speakers have talked about this as well too, what are the policy and system opportunities that are still on the table? When 1115 waiver rolls out, it's not a complete package. It's not all the questions have not been answered, and there's going to be opportunities to guide those systems and to guide those policies, and that's where you really have to be looking for those opportunities because those are some of your toe holes into the process with the state and with your partner agencies. So the first thing I'll say is one of the things that we've worked really hard at is building relationships with state officials. And one of the ways that we have done this is through our Outreach and Enrollment Subcommittee. This is a subcommittee of our Louisville Board of Health. We have been meeting continuously since 2013, and it's actually chaired by Family Health Center CEO Bill Wagner. And this particular committee is tasked with getting as many people here in Louisville, Jefferson County enrolled into health care coverage and to maintain that coverage. And with the Kentucky Health rollout, our focus has been the maintenance of health insurance coverage, in particular Medicaid coverage. And this group has got a good, solid participation. We typically meet monthly, but it's people involved in health insurance enrollment. So we've got FQHCs, our PCA, groups that represent special populations like our refugee population, our state advocacy groups, the state Medicaid managed care organizations, and we always invite and have regular attendance typically from state officials. Before Kentucky Health in the Beshear administration, we had the officials who were running Connect, our state health benefit exchange, who were active members. And when under the Bevan administration, we invited and had good participation from our deputy secretary that was leading the waiver implementation, Christy Putnam. But with that, we had something to offer them through this committee. The state is going to be looking for different wins, and what this particular group had for them is, one, this was a good place to share information. Everyone had an opportunity to kind of give updates on what they were doing and what they were seeing on the ground. So this particular group was known as a good place to learn information and also share information. And the state was looking for that. They wanted stakeholder input on the 1115 waiver. They wanted to kind of get in front of the customer and be able to maybe talk about things where they felt like there was misconceptions out there or unanswered questions. And this particular group offered them the opportunity to get in front of, the largest urban area in the state with stakeholders that really mattered in this process, very active stakeholders. So, we did have active participation from high-level people in this process. And what we were able to gain is, first we could ask very specific, very granular questions and concerns about different policy areas with the waiver. We could ask things like, how will people be able to track their work hours if they're not, don't have easy access to a computer or a smartphone? And, who counts as a medically frail? So being able to kind of have this level of conversations and have a good back and forth, we gain not only a good channel of communications with people at the state, who are in decision-making positions, but we were able to have good working relationships. And, if we started a conversation and there was I don't know the answer to that, but I'm going to get back to you, we could follow up and feel confident in sending emails to a deputy secretary, in charge of all of this. Part of the Board of Health, the Board of Health relationship building works for us because we had value. We had value for the state. And I think it's really important for everyone in thinking about this to be experts in this process, and to be able to show your value to the decision makers. And what I mean by that, states are implementing policy and creating policies, but we're the ones who are seeing the patients and interfacing with the systems that they are creating. We're going to know when there's a problem often before they're going to know. And we're able to look at their policies that they're writing and be able to say from our patient perspective or our organizational perspective what the likely impact will be. Don't underestimate your value in that area, but really take the time to become experts in what the waiver is saying and then understand what the likely impact is going to be in the various areas, because that's going to be your value to a state decision maker in this process, I think. If the state asks for help, please say yes. You're going to develop relationships at multiple levels that are going to be helpful for that ongoing engagement. One of the ways that we were able to do that when the state wanted to switch our system from the Connect system to the Benefine system, they had some problems. They had some significant problems with that. We invited programmers to come into our health center. We had in-house enrollment assisters who were experts in using this system, and we sat down with them and did, had a 100 list of cases to go over with them where we could point out problem areas, things that were there that weren't there before, and really kind of get into the weeds on this issue. So in the future, when they wanted to do updates related to Kentucky Health, they invited us back to do system testing, and we were able to bring, again, problem cases and unique scenarios to really test their system and whether or not it would hold up, in real-life scenarios. We found consumers to do the consumer testing for them. They asked us to review their system manuals and provide feedback on language for materials they were sending out. We hosted state trainings to kind of cover this Louisville metro region for them. We wanted to be helpful because we know that engagement is two ways. They're going to want something from us, and we want something for them. So, be helpful to them if you're in the position to do so. It really does pay dividends down the road. Through our relationships with the deputy secretary and our ongoing engagement in this process, one of the things that we're very concerned about from a policy perspective was the medically frail process. Medically frail within Kentucky Health was a special population group who would not be subject to cost-sharing path requirements or this alternative benefit plan, which actually kind of took away dental and vision benefits. So this was a protected group of people who, if you got that status, that was a good thing. And within it, there was a chronically homeless subcategory. So if you qualified as chronically homeless, you were automatically given this medically frail status. And this was in the whole medically frail process was something there was a lot of wiggle room on the table for system changes. Initially, when they rolled out kind of the draft forms of the medically frail, chronically homeless was defined as 12 months continuously homeless on the streets or in shelters. And we thought that was pretty problematic for our homeless population because we knew that they might sleep on, a friend's couch for a while or leave the state or, be on the streets for a certain period of time and then maybe have housing for a little bit. So 12 months continuous homelessness would qualify very few of our homeless patients in that medically frail status. So this was an area that we really wanted to engage the state on and be able to provide our level of expertise. We have a healthcare for the homeless site. We know this population better than they do. So we invited the state leadership to come to Family Health Centers Phoenix, our healthcare for the homeless site. We took them on a tour of our facility. We had data sheets for them that talked about the unique issues that the homeless face in terms of their burden of chronic disease and comorbidities. We talked about our comprehensive level of services that we provided that were really needed to address this population, including housing, including substance use and psychiatric services. And we also provided data and information about how this comprehensive level of service, including housing and peer support specialists and everything, how that helped them in the downstream costs of this costly and vulnerable, very vulnerable and high-cost patient population. So we had data from our own patient population that said, when you do all these things, you can see a reduction in inpatient care, and you can see a reduction in ER use and long-term psychiatric inpatient care. So, being able to show that this is a group that's worthy of having that medically frail status because that's going to save you money downstream. And we also talked about things that we thought would be valuable to the state as well, too. We talked about the HMIS system as possibly being something that the state could interface with in the future to maybe automatically designate people as medically frail under this chronically homeless status. So it was those kind of back and forth conversations that we wanted to have. And at the end of the day, when the medically frail process was finalized, the definition of chronically homeless went from 12 continuous months to three continuous months of living in shelters on the streets. And this was a huge win for our patients, we felt, and not just the result of the work of Family Health Centers. There was a lot of different groups within Kentucky talking about the chronically homeless and talking about the work of homeless organizations on behalf of them. We had similar work being done advocating for the victims of domestic violence, being part of this medically frail group as well. A lot of work, a lot of people talking about the refugee population. They were not included in the medically frail, but the domestic violence victims were. So this is just an example of an area where there was, the policy and the systems were not 100% complete, and we knew that there was opportunity to shape the outcome of those policies by engaging decision makers, by educating them, by kind of giving them opportunities to see maybe further wins down the road, and talking about the value of keeping these folks in continuous coverage in Medicaid. Family Health Centers has done a lot in the area of public awareness as it relates to the media, especially initially when the 1115 first rolled out. All eyes have been on Kentucky for a long time. In the beginning, when our governor decided to create a state-based health exchange and expand Medicaid with no string attached, all eyes were on Kentucky because we were this the only southern state or the only red state to kind of embrace these fundamentals is the Affordable Care Act. And when the 1115 waiver rolled out, we were the first state to say that we were going to do a work requirement. So there was a lot of attention put on Kentucky about what the likely impact would be on this waiver. And, family health centers, our decision was that we wanted to talk about it. We wanted to talk about what the potential impact would be for our patient population and our health center. And everything that I have here, these are all headlines of stories that ran. This is just some of them about that we participated in about the waiver initially. And, working with the media, first you have to really know your tolerance for being a public figure. You have to have a balanced and measured approach when working with the media. The media can be a really great way to increase the awareness of large swaths of your population. It can be a good way to influence public sentiment about the waiver and to begin to understand that changes are coming. And as a way to encourage people to be a part of the process, whether it's leaving comments in the CMS period or taking part in, state meetings that were happening across the state. And I think for us, and I think this is just, good advice in general with working with the media, policy is fair game to talk about. We feel like it's okay to critique policy and have good data and those sorts of things, but we never critique the people behind it. I think in talking about your vulnerable populations, you have value and you bring a perspective that's valuable in this conversation. But if you don't want to be a public figure, there's other ways to kind of facilitate these talks. You can always help connect consumers to media. They're always looking for that public face of Medicaid or a public face of the patient population who are going to be affected. We always keep a running list of potential media contacts for that purpose. And I would also say, we have good, strong advocacy groups on the ground, and in particular, Kentucky Voices for Health here, that's our state patient advocacy group, the Kentucky Center for Economic Policy. They have been really great in terms of helping to organize and focus messaging and communication and actions in the 1115 waiver process, and they can also be that public face in the media if you don't have a whole lot of tolerance for being that public figure, or sometimes you might want to lay low, or you might feel like you have said enough. These are the kinds of groups that can really kind of be that face for not just community health centers, but patients that we represent. So I think if you have these groups in your state and you're not supporting them or not connected with them already, please do. Kentucky Voices for Health and the Kentucky Center for Economic Policy, they've been really great from the very beginning in terms of connecting us with other states to learn about the waiver process, for doing data and impact analysis, for helping to put together talking points and messaging and communications, and along with our PCA as well too. But again, there are things that maybe our PCA or we as a healthcare provider maybe don't want to do in our roles as healthcare providers, but these folks who are a little bit more independent from the state can do on your behalf or on your patient's behalf. And in Kentucky, that this awareness, is a really important thing. For the majority of Kentuckians today, this is a 2018 poll, 66% of voters in Kentucky support keeping Medicaid as it is. And this is an election year in Kentucky where the Medicaid and the Medicaid waiver is going to be something that's, a major point in this election. So sentiment and using, things like the media can be helpful in this process. Just have a plan moving forward, and again, focus on the policies, not the people behind it, and use good data. preparing your patients and your staff. The complexity of Kentucky Health, our 1115 waiver, and Bethany understands this very well, cannot be understated. And we knew that the patients were going to find out that they no longer had Medicaid coverage when they were coming to us. Either when they were picking up their prescriptions or coming in for appointments. So we had to prepare our staff with what to do because they were going to be the ones that were going to have to deal with patients who were in penalty periods, and they were going to have to be able to provide them with solutions. This is just an example. This is the state was their communication plans was really to just send out official notifications to Medicaid enrollees and leave the communication parts to the Medicaid managed care organizations in our state. So that's another layer because we had 5 different MCOs kind of talking about different elements of the waiver in 5 different ways. So we knew that our patient messaging had to be very, very simple. And so one of the things that we did is we developed plain language guides on the waiver that were these edible chunks of the waiver. Like, what can we talk about in a half sheet using plain language that's going to help people not get kicked off of coverage or not face some of the different penalties. So we created half sheets on, kind of one that was just an overview of the waiver, one that focused on the medically frail process, path engagement hours, another one on premium and co-pays. We vetted this through our health literacy committee and with our patient advocacy, with our patient advisory group, and we shared it with our partner agencies, which is how we got all of them translated and had it available in multiple different formats. And they were really designed to have a conversation with our patients and to provide them solutions. We say in all of them, Family Health Center is here to help, and here's the phone number to our outreach and enrollment folks, because that's really what people needed. They needed a simple solution, and that was something that we could tell all of our patients and all of our staff that's very easy to remember. We're here to help. Here's our phone number that you can call. With our staff, we spent a lot of time preparing our staff on this, and part of it was really being, we've been talking about the waiver for nearly 2 years at departmental meetings, at our executive staff meetings, at our site level meetings. It's really been top of mind for us. We encourage our staff to take part in the public comment periods and provided them with talking points or encouraged them to submit in their own words what the waiver would do. And this was a stepping stone for further staff engagement in the process. When it came time for the implementation and really understanding our internal processes, we trained the heck out of people. If there was a state training program or webinars, we participated in it. We had internal committees and several subcommittees that looked at very specific parts of the waiver. For our providers and nursing staff, we trained them specifically on how to complete the medically frail attestations and how to identify patients who were potentially medically frail, and what was our process for submitting those to the MCOs. For our front office staff, we focused on, how to identify patients who are in those penalty periods and how to get them to our outreach and enrollment workers as soon as possible. Our dental team, how to reserve My Rewards dollars. So it's very role specific and focused on our workflows because we knew the complexity of the program, and we did not want to overwhelm our staff either. So we focused on the awareness, solutions, and how does this affect what I do. But don't skip on that. That's, people know it's going on and they're going to want to be informed. And I think it's, when you become experts, when you do your due diligence in order to engage with the state, that's going to set you up for success in terms of the implementation at the site level. Because again, our goal was to keep as many of our patients enrolled healthcare in Medicaid as possible and reduce the impact in terms financially of our organization. So you really have to prepare your staff in order to do that. Some last thoughts, and I think this really kind of echoes some of the things that Bethany said earlier. You need to have ongoing engagement, whether throughout the process, there's turnover at the state or people move on. So keeping that engagement throughout, make sure that it's going to ensure that you have you're going to have those connections and relationships later on when you need it. Don't wait to engage. Please engage early in the process where there are still outstanding policy questions and system opportunities where you can influence those outcomes, and there's still seats at the table. You want to be seen as the expert. You want to be seen as the expert in this, and you want the state to be able to come to you with your thoughts and opinions. So please engage early in this process. And remember that engagement's two ways. The state is going to be looking for wins. Please try to find those. Please try to find some of those wins for them or bring solutions to the table. In Kentucky, where there was a lot of problems with the waiver, we still wanted to be able to provide solutions where we could. That's part of the value that we were able to show and to demonstrate and to be able to be active in that process. And I know it's past that mark. And I kind of ran through a lot of different things, but I'm happy to answer any questions that people might have.
Thank you so much, Melissa. Really appreciate that. Such inspiring work that you guys have done and such rich content. I didn't want it to stop. We know we're at time. If you do have questions, please put them in the chat box. Melissa did graciously provide her information, so if there is no time, you're welcome to reach out to her. We did just want to do a quick reminder to please do an evaluation for us. The way that we can make these better and more pertinent for you guys is by you guys letting us know what else we can do. So we very much appreciate if you complete that. We'll also follow up with an email. Do want to just pause if there are a quick question or two. Otherwise, we want to thank you all so much for participating in this learning collaborative. We know it's been pretty intense over this past month, meeting every week, but we hope that you have great. Jen just sent the evaluation link in the chat box. Thanks, Jen. But we hope that you have learned the landscape, how to design a model, and then ways to engage in the process so that you guys can leverage Medicaid opportunities for social determinants of health. We will still be monitoring the Slack over the next week, several days. So if you have questions or want to share on Slack, please feel free to do so. Otherwise, thank you all so much for participating, and we'll be in touch. Thank you all. Thank you, Melissa and Bethany.
Thanks, everybody.
Bye-bye.